Out again.
Sure, sir. I'll be there.
Yeah, just 1 second. Okay, all those folks who have come, and I'm sure more will be joining in the next few minutes. But to keep the fact that Jessica is spending a Saturday with us, and I want her to be off at the planned time, so but promised time. So first, welcome to all of us in this BMMSH Finlay uh, conference, webinar. And I'm delighted to introduce Jessica Geiger. She was in the second batch of our students. She graduated in 2011. And I have to tell you that she was an excellent student. Okay. That's I'll remember about her. I didn't see her for a long time. Now, 1 decade later, I get to listen to her presentation on pain management at the APHA meeting in 2022. It's at one time I may have been her teacher, but that day she was the one who is teaching me about the intricacies of managing pain in real life. After the presentation, I asked her whether she would like to address this group, and she gladly agreed. When she shared her CV, I mean, that's the first time I've seen her CV basically, I clearly recognize that she has taken the mantra of lifelong learning to heart. Okay. After graduation, she did a residency and followed a master's in science. Then in 2020, she did an ASHP pain management certification. In 2022, she did ASHP opioid stewardship certification. So I'm certainly proud of her professional achievement, and I'm glad that we get to teach her at one point in our life, and she was a former student of UF. I'm sure she represents UF very, very well wherever she goes. So I first thank her for spending her Saturday with us. And she also mentioned that she has been doing some webinars with the Tata group in India. So I'm actually very glad that Indian pharmacy and Indian hospitals are reaching out for pharmacies with expertise in other part of the country, even without me introducing them. So that's wonderful. So I believe that all of you, right now, all the 11 of you who have come and those who are joining, we learned something about how the pain has to be managed or how Jessica does it in her ambulatory care practice. And I invite all of you at the end of the presentation, if you are working in a hospital or any setting in India, and see what the differences are between what she teaches you today and how you manage your own patient. If you can make some notes, I will have this webinar. I'm recording the webinar, so I'm going to share the link in my YouTube channel. So check that out. And if you can write an article, I will be happy to consider for publication in the Global Health Online Journal. So I don't want all this to be passive presentation. Don't please just tell me she did a good job. I know she will do a good job. Okay, otherwise I'm not going to ask her to speak to you guys. But if you can learn from this thing and how things are different in India, we don't use opiates anywhere near the way they use it in America. And opiate is a problem in America. But how do you use it? And is there anything which you can do in India, an Indian situation with the drugs available, which can improve the patient outcome? Write it as an article. I will be happy to consider it for my Global Health Online Journal. Having said that, I give this now presentation to Jessica. I welcome again, Jessica. I'm very, very happy. Thank you very much.
Thank you so much for having me. I'm so happy you guys are with us today. Excuse me, I'm fighting a little bit of a cold, so I apologize if I have to stop and cough. But what I want to talk about, so what I talked about at the conference was the question they asked me to answer was, when are opioids the right choice for pain management? Because I will start out by saying they aren't always the right choice. We are dealing with a problem here in the US. You guys probably are already aware of it, and we don't need to belabor that topic. We've gone a little bit overboard with opioids, and we're doing what we can to start to scale that back. But at the same time, we have to appropriately use these medications because they do have a place in therapy. So some learning objectives. I'm just going to review some pain types, discuss some guidelines that we have here in the US, and then identify appropriate use of opioids for pain management. So some questions I want you guys to think about while we go through this. You don't have to answer anything right now, but I will ask you for your input at the end is, first question, opioids are not considered very effective for which type of pain? And you can see a list of questions there, and these will pop up at the end too. You don't have to remember the questions or answers. What is an appropriate number of days for an opioid prescription for an acute surgery? And which of the following is not included in the NCCN, so National Comprehensive Cancer Network guidelines for management of malignant pain? So you're probably wondering about me, maybe a little bit, and I pose the question of, what do you think roller skates and the United States Marine Corps have in common? And you might not think that there's a lot in common with those two things, but what I will tell you is it's me. I am a chronic pain patient, and that's what got me so passionate about this topic. I grew up experiencing how it's done really badly, and I wanted from a young age to be part of the solution for doing it better. When I was 14, I was roller skating and I fell. My feet went right out from underneath me and I landed right on my tailbone. And I dealt with that for a long time. And then when I was in the Marine Corps, I was injured again doing hand-to-hand combat. You can't see me fully right now because I'm in a chair, but I am not a very big person. I'm barely 5'1". And every time I tell people that I was in the United States Marine Corps, they get big eyes and they're like, no way, you were not. But I promise I was. I did that before I started college. I did that right out of high school. So I'm now 42 and I've been dealing with pain for almost 30 years. So needless to say, I'm really passionate about this. So I do apologize. The statistics I have in this presentation are in the United States. I do not have statistics for India, but if you don't know them, I would encourage you to find them, see if they exist. Go out and look to see how much does chronic pain affect your population. So in the US, chronic pain affects 11% of the population, and an additional 25 million people each year experience acute pain due to injury or illness. One thing I want to highlight is that increased opioid prescribing, like on the other hand, in other literature, we find increased opioid prescribing does not always equal decreased pain. So right there, you can see, opioids probably aren't always the answer. And up to half of patients who take opioids for 3 months remain on them 5 years later. So that's a problem, right? We shouldn't have people who, maybe started on opioids for 3 months still on them 5 years later, unless it falls into one of the exceptions that we'll talk about in a little while. And I'm going to skip through these. I thought I hid these, but I did not. So actually, I will ask, who has ever talked with a patient? Have any of you ever talked with a patient about uncontrolled pain? Yep. And if you want to put it in the chat, you can. Yep. And if not, that's okay. If you want to open your microphones and talk, that's also okay.
Please respond. There are right now only 14 people and I want to be interactive. So yeah, unmute, respond, or at least put it in the chat. Okay?
And if you haven't, I'd love to know if this is a new thing to you, because
it's very likely many of the Indian pharmacists have never given opiates. So yeah, just please, either way, respond, please.
And I will say that as a pharmacist, I am kind of an exception to the rule. And those of us, okay, Sunita, you said yes. How did it go for you? If you don't mind opening up your microphone and chatting for a second, how did you feel when you talked to someone about their uncontrolled pain?
Unmute, Sunita.
Or if you want to type it in the chat, that's okay too. Maybe we'll come back to this one. I will share,
She's unmuted. So
oh, there we go.
Yeah.
Yay. Hi.
Yeah.
Hello,
Sunita,
sir.
yeah. Respond to the question, please.
How did it feel when you were talking to someone about their uncontrolled pain?
We just look into the history, like how is the pain? Is it radiating? How long the pain is persisting? It's for our 10 minutes or 5 minutes. It's what we say. The pain is at particular point of place, or it's a radiating pain.
Okay.
That's it.
Well, but what you're describing is this can take some time, right? It's not a quick conversation. You have to spend some time to really get an idea of how someone is feeling. And sometimes what I will say is you feel like, I'll answer this question. I have felt so many times like I can't make a change. I feel so stuck, that someone is feeling terrible and I don't feel like I can help them, but it takes, and it, I say all that to say it's a hard process, and you really have to start to gain someone's trust to get them to talk with you about something, especially if they've had experiences where people didn't believe them, right? If someone didn't believe them that they had pain or tried to brush it off like it was no big deal, it'll be fine, I'm not going to do anything for you. So thank you so much for chiming in. I appreciate that. So I also want to talk about the topic of stewardship. So stewardship is defined as the responsible overseeing and protection of something worth caring for and preserving. And the National Quality Forum came out with a paper on opioid stewardship specifically. And you can see the different topics, of things that they would encourage organizations, healthcare systems to focus on. So promoting leadership commitment, implementing organizational policies. So at my hospital, we have, some policies on what's the maximum starting dose of an opioid for someone who's never been exposed to opioids before, because we want to be very safe about what we're doing. To name one, we have a policy that anybody who's prescribed an opioid in the hospital also has availability of naloxone, or Narcan is the name brand here in the US, but the reversal agent for opioids is available to the nurses. So if something happens, the nurses can act quickly. And then on discharge, we always write a prescription for naloxone, the intranasal naloxone, when someone goes home with an opioid for safety. There's lots of other things. We don't need to get into the nuts and bolts of what my hospital's doing, but just having policies in place for safety, right? And appropriate opioid use. They want to advance clinical knowledge, expertise, and practice. So you'll see the American Society of Health System Pharmacists have, I completed their certifications. They've done one in pain management. They've done one in opioid stewardship. In the US, we also have specific postgraduate year 2 residency programs in pain management and palliative care. So, there are also other organizations that are advancing knowledge, expertise, and practice. Today would be considered something like that. I'm giving you guys some education that you can hopefully apply to something that you're doing. That also applies to enhancing patient and family caregiver education engagement, helping them understand what these medications are for and why they're being prescribed. I've had many a patient who has said to me, excuse me, I don't want any opioids because I'm going to be addicted to them. Because of everything that happens in the news here in the US, everybody is afraid of opioids. And so I spend a lot of time educating families and patients on, you have a reason for using this medication. It's appropriate. It's just like, someone who takes insulin for diabetes, we would never say that they're addicted to insulin, would we? We would never use that word in a sentence, but it gets thrown around all the time about opioids. They're dependent on that insulin to function appropriately, to function the way they're hoping to function. And a lot of the patients I take care of have cancer-related pain. So we're encouraging them to use these medications because they're appropriate in cancer-related pain to function the way they want to function. And so I spend a lot of time educating patients and families because there's a fear of these medications. Oh, I don't know what happened. We also want to track, monitor, and report performance data, just some benchmarking, establish accountability, and then support community collaboration. Some other goals are to combat the opioid crisis that's happening here in the United States. I hope that other countries don't ever have to deal with what we're dealing with here. Improve clinical outcomes and have some regulatory compliance around these topics. So let's define pain. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional response associated with actual or potential tissue damage or something described in terms of such damage. But I like this one better. Pain is whatever the person says it is, because there are no labs. There are no labs we can draw or tests we can run to find out how someone's pain is acting or what it feels like or how severe it is to them. We have to believe them, and that's hard. It's really subjective. There are a few things that will happen if someone's in acute pain, and I'm going to use myself as an example because I've been dealing with this for the past 2 weeks. I actually fractured my back 2 weeks ago, and I went to the emergency room and I watched my vitals go up. So when someone's in acute pain, you can see their vital signs increase. My respiratory rate was elevated, my heart rate was elevated, my blood pressure was elevated. You're only going to see that in acute pain. If someone's in chronic pain, you're not going to see those changes. So it's completely subjective. You have to just believe what they're telling you that their pain experience is, and asking the questions. How does it feel? Where does it go? You know, how bad is it? All of those things to really get a good picture of what that person is experiencing. So to be able to interpret what a person tells us into a type of pain and then a subsequent treatment plan, we have to review a few concepts. So pain pathophysiology, you guys have probably seen this in your education somewhere. And if not, this hopefully isn't the first time that you will see this moving forward. So when we have a pain signal, so I, poke myself really hard with something. Transduction is my body turning that poke or hot hand on the hot stove, you hear that one, turning that stimulus into an electric charge that is then used to signal different parts of the body. Conduction, the impulses from the primary nociceptors go to the spinal cord. So if it's on my hand, the primary nociceptors here on my hand signal to my spinal cord. Transmission is when that impulse goes from the spinal cord up to your brain. And then perception is then me being aware of it. Now, for those of you who have ever done anything like that, slamming your fingers in a door, stubbing your toe, or any of that, that happens this quick. It happens way faster than what I even just described it. And then we have modulation, which is this fifth part of a pain pathway, but it happens simultaneously. So at the same time that all this is happening, where the signal's going to the brain, modulation is happening where it's kind of a descending pathway, if you can think about it, where it's then changing how we perceive the pain. So different chemical transmitters and neurotransmitters are being released to change the perception. We also need to talk about acute versus chronic pain, and then nociceptive versus neuropathic, inflammatory, and mixed pain. So acute is, pretty self-explanatory. Short-term, sudden pain that usually doesn't last really long. Chronic pain may not have an obvious cause. And like I said before, you may not have a sympathetic response, but it's pain that lasts longer than 6 months. And then we need to talk about the different pain types. So I'm just hitting the tip of the iceberg on these things. I have done education where we do a whole hour on just the types of pain. So you guys are just getting a snippet of this today. Nociceptive pain can be broken down into 2 categories, somatic and visceral. So somatic pain is going to be very easy for someone to describe. So for me, I'll use me as it's great when you can use yourself as the example in these cases. My pain was in my back. I was able to point exactly to where it was. I was able to describe it really well. I was able to talk very specifically about how it was affecting me. And it turns out it was bone damage, right? I had fractured some bones. Visceral pain comes from your organs, and it usually is almost a referred picture of pain. So it's very hard for people to describe pain like this. The most common example I see is someone who has cancer that has spread to their liver. And just kind of, if you think about it, our organs aren't built to have room for other things to be in them. So as tumors grow inside the liver itself doesn't have the nociceptors, but the capsule that surrounds the liver does. So as the liver is being forced to stretch, that capsule stretches, and that causes a lot of pain for these patients. But the way they describe it might be flank pain, or this this very generalized abdominal picture, or even back pain, but really it's coming from the liver. So it gets really complicated when you start to get organs involved. And the best way to figure that out is to have a physician order a scan to figure out if we can see where this pain is coming from. Neuropathic pain comes from nervous system damage. So it can either be a lesion of some sort, or it can be dysfunction. And the thing that happens here is that pain that is described may be huge compared to the observable injury. And what happens in neuropathic pain is that something has gone awry with that pain pathway that we talked about earlier. The nervous system is just not functioning the way we would hope it would, and it's causing problems. This is where you're going to have people describing pain that shoots down their leg or that shoots down their arms, that radiating pain that we were talking about earlier. And finally, we have to talk about an assessment. And I am highlighting quality because quality, when someone describes quality of their pain, so the description of how it's feeling, that's when you can start to determine, is this nociceptive? Is this neuropathic, inflammatory? I don't have a slide for that, but that's pretty self-explanatory. Swelling, swelling is causing pain. What can we do to decrease the swelling, to decrease the pain? And then mixed is any combination of those other pain types. So when someone gives you their pain description, I always hope for a really good one because it gives you an idea of what kind of pain they're having. And that helps you just start to put those puzzle pieces together and come up with a good treatment plan at the end. So the assessment tool that I use is PQRSTU. There are a lot of assessment tools out there, and I just encourage you to find one that you like and then stick with it. It makes it hard if you bounce back and forth. So this is the one I use: precipitating and palliating factors, previous treatment. So all of those P's. Quality we talked about. R, region and radiation. So where is it and does it move around? Severity, that's your pain rating scale. So 0 is no pain, 10 is the worst pain you could ever imagine. Temporal profile, so the timing of the pain. Are there certain times of day that it's worse, certain times of day that are better? Or is there no temporal profile to it and it just happens? And then U is my favorite question. And it all revolves around, how does pain affect the patient? And the question I like to ask people for this is, what can't you do now that you wish you could do because of the pain? And you'll find out a lot of information of how the pain is affecting someone functionally. So a quick review of the Centers for Disease Control guidelines, which is something that we have here in the US. These guidelines were written to stress appropriate assessment, dosing, treatment duration, and risk benefit. They suggested some morphine milligram equivalent, and you'll see me abbreviate that as MME, throughout the guideline. And they said, anybody who's on more than 50 morphine milligram equivalents should have careful reassessment. So just follow your patients, right? Keep track of them, check in on them, have appropriate follow-ups. And then they said in the first iteration of these guidelines that MMEs greater than 90 should be avoided without justification, or that the patients didn't fall into a certain exception. They also provided suggested timeframes for treating acute pain and limiting prescriptions to no more than 1 week. So these guidelines are currently under review, and I think a new version of them should be coming out soon. The exceptions carved out for that greater than 90 MMEs were for hospice and palliative, and for patients being seen by a pain specialist. Now, what happened with these guidelines in the US is people used them for everything, and they would say, I can't write a prescription for more than this. Or patients who were on more than 90 morphine milligram equivalents were just rapidly titrated off of them, and they were experiencing withdrawal symptoms. Or they couldn't get in with a patient with a pain management specialist, and they just went through withdrawal because they had no one writing their opioids. These guidelines ended up, they were intended to be a guideline, not a written in a stone tablet, this is what we will do now. They were meant to be a guideline for just appropriate opioid use, and it turned into something that I don't think the writers of this guideline ever intended. That's my opinion of that. I don't know any of the writers of the guidelines, so I wish I did so that I could ask them. So some common pain syndromes that I want to go through today are acute post-surgical pain, neuropathy, musculoskeletal pain, malignant, and sickle cell. So some more statistics for you guys. after. So we're going to start, I should say this, we're going to start with acute post-surgical pain. So 80% of patients with acute post-surgical pain receive opioid prescriptions. 72% of those prescribed opioids go unused. And I want to highlight that because that was one of the pieces of what we thought was contributing to the opioid problem in the US was all of these unused opioids. They thought, well, was it from overprescribing? What was it from? And we had all these unused opioids just sitting in people's houses, and they were worried that, what happens if those end up on the street, right? Let's help people get rid of them appropriately and encourage them to not save unused medication. And then 6 to 10% of people continued to fill opioid prescriptions 3 to 6 months post-operatively. So right here is also a problem. It's what's going on that their acute post-surgical pain is continuing 3 to 6 months post-operatively. There is Michigan, a state here in the US, has this open network. It's the Opioid Prescribing Engagement Network, and it's fantastic. I did a lot of digging into this, and they have some good things in place. They talk about utilizing prescription drug monitoring review. So do you guys have a PDMP in India? Prescription drug monitoring? So this is a thing we have here in the US where we can look to see someone's fill history, regardless of what pharmacy they went to, for controlled substances, which makes our jobs as pharmacists a little bit easier in the US because you can start to see, you're like, that looks funny. They just filled a 30-day supply for this at a different pharmacy 2 days ago. Why are they back here now trying to fill another one? Or look, they've been filling things very consistently for the past 30 or, past several months, 30-day supplies at a time. I don't see an issue with filling this prescription. So it really gave pharmacists a lot of information.
Jessica, they don't have it in India. I know that.
Okay. So I wish you did. It makes your job a lot easier. It makes your job a lot easier. And then the Open Network also talked about maximizing non-opioid and non-pharmacologic interventions. I think so frequently we forget about the non-pharmacologic interventions, the exercise, staying active, doing like gentle things like some gentle yoga or body weight exercises if you can't go into the gym and lift heavy weights. I know I can't do that. Just getting out of a chair, getting out of that sedentary position and moving around. It might hurt at first, but it's really good for people. It's good for our bodies to stay moving. Massage therapy, acupuncture. I think I could just go on and on about the options for non-pharmacologic interventions and how helpful they can be for people. When we talk about non-opioids, I'm talking about acetaminophen, ibuprofen, gabapentin could be options to help treat pain that are not an opioid. And then when we do use opioids, using them at the lowest effective dose for the shortest duration of time. And that's not a new concept. We talk about that in all different places in pharmacy. Blood pressure meds, start low, go slow, right? Like you hear people say, start low, go slow all the time. And that applies to opioids as well. We don't want to just give someone a big dose when a little dose would suffice. So that's acute post-surgical pain. Now let's talk about neuropathy. And I want to look at what the literature says, excuse me, about neuropathy. So from this article, and you'll see a lot of these articles that I've pulled are older. This one's from 2005, but it was a great overview of treating neuropathic pain. And first line, tricyclic antidepressants, serotonin, norepinephrine reuptake inhibitors, and gabapentinoids. I do not see opioids in first line, right? Second line, combination of first line agents. So if we already have a tricyclic antidepressant on board, maybe we add a gabapentinoid, and we have 2 from that first line therapy. And then we consider adding tramadol. Now, tramadol is a very weak opioid. Technically, yes, it's an opioid, but I almost don't consider it an opioid. So, I can see, tramadol. Tramadol also has some really neat effects of modulating norepinephrine and serotonin. So it helps in modulation, and it can really help in neuropathic pain, which is cool. So tramadol can be a great option for neuropathic pain. Third third line, selective serotonin reuptake inhibitors, so SSRIs. You saw in first line, we were talking about SNRIs. Now we're talking about using one second, something's happening in my house. So then we talk about using a selective serotonin reuptake inhibitor. Fourth line, N-methyl D-aspartate modulation. So these include ketamine and methadone. Again, going into detail about ketamine and methadone is another 1 hour talk. So I'm not going to go too deep into that. And then considering anticonvulsants. You will notice that opioids do not show up until last fifth line, opioids for neuropathic pain. Fifth line. So we should really be trying to maximize these first through fourth line treatments before we try to use an opioid for neuropathic pain. To get a little bit more, detail on antidepressants. So if we're looking at, first, I'm going to look at here TCAs, so tertiary amines, so something like amitriptyline. They work by, you can see all of these work by modulating serotonin and norepinephrine, right? And I've given you some dosing. What I can tell you that for TCAs for neuropathic pain, you generally don't have to use high doses. I've never seen anybody get really much higher than 30 milligrams a day on something like amitriptyline for treating neuropathic pain. When you see these higher doses of TCAs, that's usually for depression, and we generally don't use TCAs for depression anymore. The side effects for these can be quite problematic if you think about, if you're going to think about using these for geriatric patients because of the anticholinergic burden that can happen. So thinking about dry eyes, dry mouth, constipation, urinary retention, those can be very problematic. They can be sedating. So if you're using these medications, they should be given at bedtime. And you can also see QT prolongation. If you're looking at secondary amines for tricyclic antidepressants, it's the same kind of same dosing strategy. You start at 10 and you go slow. You see some anticholinergic side effects, but not nearly as much as the tertiary amines. You can have sexual dysfunction and again, QT prolongation with these. And then I'm going to talk about venlafaxine and duloxetine, which are two serotonin norepinephrine reuptake inhibitors. And the thing I'll highlight here is that really what we've found is the SNRIs are better at treating neuropathic pain than the SSRIs. That's why you're going to see them as first line therapy. And there's some dosing here again, and the potential side effects. So you can see drowsiness for all of these, almost all of these. So I always recommend if you're going to start a medication like this to give it at bedtime. For venlafaxine and duloxetine, 30% of patients can experience, up to 30% of patients can experience nausea, and that can be a reason that people discontinue these medications. Gabapentinoids. So we have gabapentin and pregabalin. They both affect calcium-gated or voltage-gated calcium channels. And again, you'll see the dosing for gabapentin is higher than pregabalin. And what I will say is patients tell me that the side effects for pregabalin are better tolerated than the side effects for gabapentin. But what we run into here is we have to sometimes start people on gabapentin and they have to fail it before their insurance will pay for pregabalin. So we have to kind of jump through a little bit of hoops sometimes. And then we talked about anticonvulsants as an option. I will share, I hardly ever recommend these because I don't really like the side effect profile of most anticonvulsants. And if I can avoid them, I will. You can see here, severe skin reactions. I never want someone to have a severe skin reaction. These are terrible. I don't want anyone to ever experience that. You can see metabolic things, electrolyte things. So I try to avoid these if at all possible. Most people don't like, if you look at lamotrigine, most people don't want to gain weight, and that's a common side effect of that one. So these are an option, but I hardly ever get to them. Usually we find we can control neuropathic pain with, first and second line, sometimes adding the third line agent and get their pain under control. So let's talk about musculoskeletal pain. This is where we see overuse of opioids commonly. Opioids really aren't the best thing to treat musculoskeletal pain. Early use of opioids has been associated with poorer outcomes in low back pain. You see people with low back pain getting opioids all the time, and it's really not the best thing for them. So, recommendations from this. This was also another great article when I read it. I'm like, I really like this article. It's from the Journal of Orthopedic Trauma, and it was published in 2019. So they came up with these 6 recommendation strategies. So pain management, of course, is number 1. Cognitive things you can do, physical means of pain management, looking at patients who are on long-term opioids, good pain assessment, and then system. So if we talk about pain management, they stress multimodal therapy is key. I agree. Using multiple agents to try to treat the pain. So, using a non-steroidal anti-inflammatory, maybe adding some scheduled acetaminophen, doing some, muscle rubs or topical agents. Those can be effective as well for musculoskeletal pain. If we are going to use an opioid, it should be, again, you saw this earlier, you're going to see it again, the lowest dose for the shortest amount of time. People with low back pain should not remain on opioids chronically. And extended release opioids should never be used for an acute injury. When we talk about cognitive portions, we need to set expectations. One of the things that I do with my patients is say, I don't think we're going to be able to get your pain to 0, but we can get it to a manageable level for you. What would that be? So getting some buy-in from your patient, but also setting that expectation that I'm probably not going to be able to get it to go away completely. And it's something that you're going to have to incorporate into your life. And then in that same vein, connecting people with psychosocial interventions. So do they need to see a social worker or a counselor to talk about how this is affecting them, or how they might modulate their life a little bit to better control their pain and better live with the pain that's still there? Physical components. So we talked about these, the non-pharmacological things, and I didn't mention ice or elevation, TENS units. So those sticky pads that vibrate and, use electric nerve stimulation on the muscles to help with spasms. Physical therapy can be great for treating low back pain. And then if we have patients who are on long-term opioids, they should only be written by one prescriber, and they should be written and used in combination with multimodal therapy, including pharmacologic and non-pharmacologic, and then always trying to taper when you can, getting someone down to a low dose. So if they needed, for example, 15 milligrams of morphine every 4 hours as needed at the beginning of their injury, maybe after a month, we start to say, all right, maybe try 7.5, and we start to taper it off. And then maybe we say, now maybe try 7.5 every 6 hours as needed. And you slowly see what, where we can get someone down to and still effectively manage their pain. Assessment. They stressed in this article, assess and then reassess regularly, making sure you have follow-up appointments. Asking, how are these medications working? If something's not working, we should not continue it. So how is something helping with pain, and is someone experiencing side effects that they just can't tolerate? Do we need to change course? System is talking about hospital systems, or just overseeing systems. So again, the prescription drug monitoring review, if you have access to that, if you're using an electronic medical record, developing clinical decision-making tools and support, and then providing education. Malignant pain. This is where I live most of my days, is helping take care of patients who have malignant pain. Cancer pain affects 30 to 50% of those receiving active treatment. So chemotherapies, immunotherapies, radiation, and it affects greater than 70% of those with advanced disease. So if you're talking about someone with stage 3, stage 4 cancer, when they have metastases, cancer pain can require high doses of opioids. And generally when someone presents with cancer pain, it's a mixed, nociceptive neuropathic and inflammatory process that they're experiencing. And with mixed pain, it is important to use adjuvant or multimodal medications for the specific type of pain. So you can use a steroid to decrease the inflammation, or a non-steroidal anti-inflammatory. You can use those medications we've already talked about for neuropathic pain to address that part of their pain. So really trying to target each, therapies that are going to hit each type of pain that they're experiencing. The National Comprehensive Cancer Network guidelines talk about setting goals. So we talked about this before, setting expectations with a patient, comprehensive assessment. We talked about that. Multimodal approach. So you can see some commonalities of how to do this right, using the lowest effective dose, using scheduled and breakthrough doses based on 24-hour use for patients who have cancer, and then decreasing if able. So current state. This is where I've seen some unintended consequences for patients that have cancer because of those guidelines that came out. They've seen delays in patient care, disruptions in treatment, insurance red tape, not being able to get what they need when they need it, and then increased workload on providers for trying to cut through this red tape and get these people what they need when they need it. And we can't talk about cancer-related pain without talking about cancer survivorship, because that's a thing as well. People who are in remission, and the American Society of Clinical Oncologists, or ASCO guidance, they looked at 35 systemic reviews, and they focused on adult cancer survivors and focused on chronic pain rather than acute. And this guidance was developed by an expert panel. What their guidance was, again, is very similar. You can see people are on the same page with how to do this. Doing a comprehensive pain assessment, screening for chronic pain syndromes that can result from cancer treatments. There are chemotherapies that can cause neuropathy. So has someone developed this neuropathy from chemotherapy? We need to continue to treat that pain syndrome. It's also appropriate to evaluate for recurrent disease. It's not what you want to think about doing, or you don't hope that for someone, but if someone is still having pain, in the oncologist's mind is, can it be a recurrence of their cancer? Do we need to do more workup? Again, using multimodal pain therapies, and conducting a risk versus benefit analysis. So is the risk of the opioid worth it? Like, are they going to get enough benefit to warrant the risk of these medications? Because there are risks, over sedation, over use of the medication, side effects that they can't tolerate. Are we worried that there might be a diversion problem? And then if the opioids are no longer warranted, tapering them. Finally, sickle cell disease. So sickle cell disease is a congenital genetic chronic hemolytic disorder that is frequently interrupted by acute life-threatening events. So patients' red blood cells, something triggers them to form a sickle shape. They start to stick together in someone's body, and it causes severe pain. Vaso-occlusive crisis is what we call it when they come to the hospital. The incidence in newborn American, in the Black population in America, is 1 in 400. And there are many different presentations. There are acute complications as well as chronic. The acute complications include acute chest syndrome. So when these sickled cells are stuck together in someone's chest and it changes how the blood flow is getting places. Splenic sequestration. So sometimes people have to have their spleen removed because it, gets sequestered, you have this sequestration crisis. Rapid and fatal anemias. And then you can see chronic complications, hemolytic anemia, skin ulceration, stroke. Most of the sickle cell patients I help take care of have had at least one stroke. Some of them had their first stroke as young as 4 years old. Avascular necrosis can happen. All kinds of things can happen as a result of this. And the mainstay of treatment for sickle cell is actually IV opioids. So the average patient with sickle cell disease has 3 emergency department visits per year. And it accounts for more than $1 billion in healthcare spend in the United States. The American Society of Hematology talks about using standardized protocols to treat acute pain, non-opioid therapies, non-pharmacological therapies. You can see this, again, carrying through from others. Managing pain in a sickle cell disease specific hospital if possible. In Columbus, Ohio, where I live, the Ohio State University has a day, they call it a day hospital, where some of the patients that have sickle cell disease will go there and they will get their crisis controlled, and then they go home. So they're never admitted, and it's a very specific hospital. And then what they recommend using is patient controlled analgesia. So that's a pump, an IV, of IV opioids, where the limit can be set by the provider of, we usually use every 15 minutes as needed. And then someone would get a small dose of an IV opioid, and they push the button and they control it. They can't, once they hit the button, they can't get another dose for that 15 minutes, but they are in charge of how much they use. And these guidelines support using IV opioids to treat acute vaso-occlusive crisis. So this is the most frequent presenting complaint to the hospital in adults with sickle cell disease. And it's just, these cells get stuck, really is what it is. The peak incident is in ages 19 to 39 years. 30% of patients can have little pain and 30% are admitted. Precipitating factors include temperature changes, stress, dehydration, illness that can all precipitate this something that causes the body to switch and cause these cells to sickle. And then the thing that's shocking to me is 22% of deaths in patients with sickle cell disease occur during an acute episode of vaso-occlusive crisis. So management of this, it's important to do rapid and effective pain control with IV opioids, give fluids if they're dehydrated, treat them if they have an infection, using incentive spirometry, anticoagulation as appropriate. Some patients need a transfusion and some patients need oxygen, but this is a place where opioids are very appropriate. I am going to move through these next ones kind of quickly. These are just some ideas, and I will share these slides so you guys can have them. Having a plan for when someone comes in with sickle cell disease is always appropriate, and they're going to be very patient specific. So you want to make sure you're using what that patient has used in the past. The worst thing you can do for someone who has sickle cell disease is underdose them. If in the past, when they've come in with a crisis, they require, 6 milligrams of IV morphine, they shouldn't be started on 2 the next time. We always want to start on the dose that has been effective for them in the past. And then once their crisis starts to resolve, either stopping the opioids altogether or converting them back to orals is appropriate, because some people with sickle cell disease will have a chronic component to their pain. We talked about triggers already. So we want to, more guidelines. The American Society of Hematology talks about they talk a lot about non-pharmacologic and non-opioids. And they also talk about, chronic opioid therapy. It's not recommended unless someone's pain is refractory to these other modalities that we've talked about already today, the SNRIs, the tricyclic antidepressants, the gabapentinoids, maybe even an anti-epileptic. And then when someone has outpatient care, having, again, a standardized approach, that's the big takeaway for sickle cell disease, is having this standardized approach. And it's very similar to the other approaches that we've seen in the other guidelines we've reviewed. Some sickle cell patients will have a standardized outpatient plan where they have an opioid at home. And if they feel like they are starting to have a crisis, they'll have instructions for how much of that they should take, how often, and then when they should go to the hospital if those oral opioids aren't working for them. The pitfalls when you see patients with sickle cell disease is communication breakdown. I see it all the time. People don't talk to each other. I don't know what their outpatient person is doing for them or what they want us to do inpatient. So on my palliative team in Columbus, we try to bridge that gap. We see discharge opioid prescribing when maybe it shouldn't happen, or it should happen and it doesn't happen. The visual analog scale is something that's not always easily used by some patients. So you can see a lot. You can see a lot here. I don't need to read to you what's on this slide with pitfalls with not just sickle cell pain management, but just pain management overall. And then finally, I wanted to highlight, you know, all of these words. People who try to seek pain, they don't always get somebody who's willing to treat it, right? They feel like they are being treated as though they're not trustworthy, or that, you know, they are drug seeking. Providers would maybe call these people emotionally draining. Some people have experienced bullying. And so these are just, you know, some words that have come up when we talk about pain management and the experience of pain management. So I would hope that this could start to change, and when we do this better. So patient counseling is always important. Asking people how their pain is responding to treatments, inquiring about duration, being aware of withdrawal symptoms if a prescription is delayed, familiarizing yourself with equianalgesic dosing, and then obtaining pertinent diagnoses if possible. This is one of my favorite pictures, and it just shows where each of the medications we talked about today is effective on, one second, where each of these pain medications is effective in the pathway. And so it's a great reference. And then finally, let's talk about our assessment questions. So opioids are not considered very effective for which type of pain? If someone could throw something in the chat.
Please do, folks. She has given you a wonderful percentage for an hour, and these are some straightforward questions. Just want to make sure. C.
Neuropathic pain is one of them. Yep. What else? Anybody else have a thought?
A. Got it.
A. Okay. Let's see here. Correct answer, A, musculoskeletal pain. Awesome. They are not super effective in neuropathic pain either. So I don't want, that's not a wrong answer. It's just not the best answer, right?
Got it.
Next, what is an appropriate number of days for an opioid prescription for an acute surgery? Perfect. C. Yep. They recommend no more than 7 days, right? So 5 days would be an appropriate amount. And then 3, which of the following is not included in the NCCN guidelines for management of malignant pain? I made this one a little bit of a tricky question. So I'll go through this one because I'll take the blame for making this one a tricky question. So they do want you to utilize multimodal pain management. They do want you to set goals. The thing here is it's only utilize opioids as a last resort for cancer pain. Opioids are the treatment, for cancer related pain, but they do also want you to utilize the lowest effective dose. So it's C that is not included. Key takeaways: multimodal pain management is really important. Target the treatment to the type of pain, and not to forget that opioids remain appropriate in certain situations. So this is that Michigan Open website that I was telling you guys about earlier. And then this is just all of my references, but I'll make sure Dr. Sekar gets my presentation and he can share it with all of you. But I appreciate your time this morning. And I appreciate you letting me teach you. This is an area I'm passionate about. So I hope that you took away 1 or 2 things that you can apply to your future, and that you found it helpful.
Jessica, thank you very much. Okay, you made me proud and made you proud. Okay.
Thank you.
And so I will let you guys in there over 18, 15 other people there. Please ask her any question. If you keep quiet, I have to let her go. Okay. And then I want all others to just stay back for a few minutes. I want to talk to you and see your video if you have, switch on the video. So any questions for Jessica? Put it in the chat box, or you can unmute yourself at this point and ask her the question directly. And I really appreciate all of you for providing a very quiet environment. In some of the talks, people have been always some extra voices were coming, which was disturbing. So thank you. And so unmute yourself and please ask the question to Jessica. Jessica, you can now stop the screen share so they can see everybody's face there.
let's do that. I always forget to stop screen sharing.
That's
The other thing I wanted to share before I go is I'm going to put my email in the chat. So for those of you that might not think of a question right now, if you think of one later, please email me.
And it's being recorded. So I will put it on the YouTube for everybody else who want to. And then please, others who are there after Jessica leaves, just wait for a few minutes. I have some questions for you and some thoughts for you to share.
Okay. I have a question, Dr. Chandrasekhar sir. Can I ask one?
Yeah, you can ask Jessica. Sure.
Yeah, go ahead.
Yeah. Good morning, Dr. Jessica. That was a beautiful presentation to start with.
Thank you.
So I have my question that how do you treat a patient who has been on a tramadol?
Oh, something happened and you got muted.
Yeah, exactly.
And that
Can you just repeat the question, Ronit?
who had been taking for course. So I had this patient and I don't know how to start with the choice of drug, whether it's methadone or whatever. So how do you do that with that opioid abuse patient?
So are you talking about if someone's been on tramadol and you want to convert them to, did you say methadone?
Yeah.
So
Yeah.
So that's a great question. That's a great question. But what you have to do is figure out the morphine milligram equivalents of tramadol, and then use that to convert to methadone. So it's a bit complicated. The other thing you can do is just start at a really low dose of methadone, like 2.5 milligrams once or twice a day, monitor that person very closely and see how they're doing, and then up titrate it. But the best way you can do it is to do that actual math calculation. And at some time in the future, if you guys want to talk about opioid conversion, I am happy to come back and go through that process as well at some point in the future. Because it's another talk all on its own. I don't have time to get into all the math this morning.
Okay. Actually, this particular patient of mine that was presented with this particular condition, she was also showing some signs of psychotic behavior. And again, if we could have started any antipsychotic medications as such, it would have also led to something which is very common with tramadol, that is a respiratory distress. So, or hypotension, for example. So how do I deal with such situations is what I wanted to ask exactly.
Okay, so it's monitoring, really close monitoring. You know, I don't see as much respiratory depression with tramadol as I do with the other opioids because it really weakly interacts with the receptor. So of any of the opioids, I actually worry the least about tramadol and respiratory depression. So you'd probably be okay if you had tramadol plus an antipsychotic. I actually see that a lot, and we tend to see it tolerated well also. So I think that would be an area where you wouldn't have to worry so much. I worry more about respiratory depression and, you know, morphine, hydromorphone, fentanyl, methadone, all those other ones.
Okay. Anyone else would like to ask a question, then you can go ahead.
I apologize. Also, I do have to hop off. I have a call I have to be on at 11.
No, thank you. No problem.
But I appreciate everybody's time today. Thank you for chiming in. For those of you that did, email me if you have questions.
Exactly.
And I will get my slides to Dr. Sakar so that you guys could have access to those as well.
Thank you, Jessica.
It was great to be with you all today.
Yeah, bye-bye.
Bye.
Bye.
Okay, Jessica has left. First, I wish to congratulate all of you who were there. So that means there's interest in learning more about it. Now, this is what I have noted. Okay, let's see here. So what I give an opportunity is to reflect on what she has told and convert it into some practice of what is happening in India, in your situation, in your hospital, and convert it into a writing, an article, which I can publish in Global Health Online Journal. For everybody, writing is difficult. Okay, I honestly tell you, I ask 100 people, only 1 or 2 people will submit anything. But that is the best way for you. That's what we learn from grant writing. Grant writing is a pain. But when you start doing it and polishing it and reviewing what you have done, you come up with something which can be done, right? And once you document it, once I publish an article, then you implement it. That could be another article. That is your way for progressing in your life. No pain, no gain. Okay. Just saying I did a certificate, nobody cares. But what did you do with that certificate? Every job person who wants to hire you want to know what can he get from you. You did a certificate is good. You come listen to the seminar is good. But nobody cares. You spent 1 hour listening on a Saturday evening. That shows a commitment. But the person who is going to hire you for the next job or the next position doesn't want just a commitment for learning, but say, what did he get from your commitment on learning? So here I have put in your some suggestions here. Okay, you can, I mean, it's being recorded, you can revisit this or make the note and write on any particular small article, 3-4 pages, require some research on what is happening in India. So these are some of my questions. Okay. Okay. Do you have pain assessment in your hospital and pharmacy? Do anybody use any type of standard scale? If you're, remember, this doesn't require any cost. You don't have to change anything. Okay. Do you ask this question? When a patient comes, do you use any standard scale? If you don't,
We do, sir. We have got pain scale as well as NPS also
very good.
in our emergency setting.
That's good. So maybe you use it. Maybe some other hospital don't. Okay. I mean, I'm just throwing out a general. Don't want a response from you at this point. Okay. That's good. Suppose in one particular situation, you're not using it. Or if you are in a community pharmacy, you're not using it. Can you choose what are the pain available and which one you like to choose? And then say choose and use it. So that itself becomes an article. Okay. From Indian standpoint, I don't know. I don't know what's happening. And what's happening in America is not immediately, I mean, applicable to India anyway, right? 7, comparison assessment tool, and then implementation. And like in this case, do you use, for simple thing, when do you use opioid in your hospital? And in America, we use, as you say, for every type of pain, you are getting an opioid prescription. That is the reason for opioid abuse, right? And if you can say that we don't use opioid, but patients are managed as well or equally well as that of an American condition, that's a beautiful article, right? So here you're using musculoskeletal pain and everybody's getting opioid, and if say 74% of the opioid doesn't get used and then goes into the open market or black market, and people are getting addicted, right? So if you say in our hospital, in our condition, we don't use musculoskeletal pain, we only use it for cancer pain, and what dose you start with? Do you use any other? Does patient usually use other non-pharmacological treatment along with that opioid? That means it will reduce the dose of opioid. Any of this, just tell me what is happening in contrast to it. Okay, do you use opioid for post-surgical pain? You can just take those 5 conditions and you say where they use opioid in America from the literature and where we use it in India, right? That's it. And what are the non-pharmacological interventions used? I believe that in India, we use homeopathy, we use Ayurveda, we certainly used yoga. We are the creators. So if you can tell us that more cancer patients in India uses yoga than cancer patients in America, I mean, read some literature, you have an article, you have something which you can think about, right? See, the point is, as I told you, I taught Jessica one day some cardiovascular pharmacology. Okay, but now today she's teaching me. You can't stop. There's nothing. We all don't know everything. I can help you do something if I know something more about what's happening in India. Okay, like in this case, it's only the 5th line of opiate treatment for musculoskeletal pain. I mean, for the neuropathic pain. Okay, so again, we can review this after at your convenience. Once you find a small topic, write down 2, 3, 4 pages, send it to Global Health Online. Just send me an email so I can send you the link of Global Health Online. And Ronit has already published one. And our articles are free. It gives you a nice free publicity. Okay, good PR for you, good, I put a picture along with it. And they're at least downloaders on an average now, 20 to 25 times. Actually, not every, I think it's an average download of your publication. So think of it. If Jessica now talked, only 15 people listen. I'm going to download it, put it on the video, put it on my YouTube channel, put it on, more people will listen. Right? So when you publish that article, that's good, and that's good for your career, and that's good for your hospital, and that's good for the patients in India, because what happens somewhere else, we don't know. We need to share. We don't know to boast about it, but we need to share. Okay. So with that, anybody else has any questions for me? Just, if you want more information, just send me an email. I will respond to you. I don't bother everybody who is not interested, but those who are interested, we can pursue from there. Binay, any words from you?
Yeah, sir, thank you so much for this session. It was indeed too informative. Even we had questions, but Dr. Jessica, she was in hurry. I guess she was committed with some other work.
Well, you can always share the video with her if she wants to watch anything. So,
Okay.
okay, so I mean, this is pretty much, I got 3 or 4. We already made 2 presentations. I will do 3 more in spring. And, you know,
Okay,
I'm
sir.
more motivated if I get a response. As I told you, my goal right now, I'm spending this Saturday with you guys, is to make some improvement. And in a year or 2, I would be spending more time in India. That's my goal, is to convert my expertise, my ability to improve networking and bring in the speakers who are really practicing to India, and and there are a lot of young people. I know many of you are staying and you are doing good work. So I help you improve that delivery. That's all. If there are no questions, just put a thumbs up if you like the presentation, so it gets recorded. So anybody who views on it, he looks what it is like. And if you didn't like the presentation, and I don't know why you would be here, you can show a thumbs down. Okay. Thank you very much.
It was really informative. So it was really good.
Yeah, no, that's my goal. I've got other students doing some excellent work. And so again, my motivation to do more will depend upon your interest and your response based on these presentations. Not the thumbs up and thumbs down. That is just for me to share Jessica that she did a good job, but to say what exactly in a nutshell you learned from it and how you can improve in any small changes you can make in your work setting will be greatly appreciated. Thank you. Have a good day. And
You have some message over there, sir.
let me look it up then. Let's see. Let's see. Session informative, you're truly inspired. Thank you for putting a spark in us to do more. Okay. Thank you very much. That's I appreciate it. Have a good day, folks.
You too. Thank you, sir.
Have a good day, sir.
Yeah. Goodbye.
Yes.